Hi everyone and welcome back to my channel. In today's video we're going to talk about the ACE inhibitors and we're going to follow the same frame. We're going to first talk about the classification, mechanism of action, the treatment, the adverse effect versus complication, the special consideration and interaction, the metabolism, route of administration and elimination, and how do we handle the toxicity. ACE inhibitor, ACE stands for angiotensin converting enzyme. Before we even talk about the ACE inhibitor, we need to know what is ACE, where does it act, and what are the effects of inhibiting ACE. So in my previous video, I used to talk about renin-angiotensin aldosterone system, and we're going to use that system to understand the ACE inhibitor. So let's go ahead and mark down that system. So we have the liver. It's going to secrete the angiotensinogen. Remember, the liver is the manufacturer of our protein. Now that angiotensinogen is going to be activated into angiotensin 1. Angiotensin 1 by the kidney secreting the renin hormone. Now this is a way step limiting in this synthesis of aldosterone. So if we don't have enough renin, this whole mechanism, this whole chemistry is not gonna happen. So renin is the step limiting of this process. Now the angiotensin 1 is going to be activated into angiotensin 2. Angiotensin 2. And this is going to be done by the lungs secreting angiotensin converting enzyme. So this is where ACE acts on. Now let's just finish the whole reaction because it's going to be helpful in understanding what's going to happen when we block this enzyme. So angiotensin 1 is going to increase the release of aldosterone. And it's also going to increase the release of sympathetic nervous system outflow. It's going to be increasing the release of antidiuretic hormone. And itself, angiotensin 2 is going to be a powerful and potent vasoconstrictive hormone. And also, angiotensin 2 is going to be able to regulate all this reaction by providing a negative feedback loop right here, adjusting the dose. So this is the basic frame of what we need to know. Now, ACE inhibitor here, the hormone ACE is also responsible of the degradation of bradykinin. And bradykinin is heavily implicated into the inflammatory process in the body. So this ACE is going to help produce angiotensin 2, and it's also going to degrade bradykinin, decreasing the level of bradykinin. Now we are talking about the ACE inhibitor. So if we inhibit this ACE here, we have a decreased level of angiotensin 2 and increased level of bradykinin. And this is going to be the foundation of understanding the ACE inhibitor. So classification, ACE inhibitor are these drugs that are going to act to break down the hormone called ACE and decrease the level of angiotensin, making all this effect voided, and increase the level of bradykinin. So ACE inhibitor is going to decrease the level of angiotensin 2 and increase the level of bradykinin. bradykinin. And this is their main mechanism of action. So why do we use them? Most of the ACE inhibitors are going to be present as prodrug. So prodrug means that this drug comes into the body into the inactive form and has to be metabolized into an active product, and the active product is going to be responsible of the clinical use of the drug. So most of the ACE inhibitors are prodrug except for three. So those three that are not prodrug, uh, captopril, lisinopril, and enalapril. Now, you're going to notice that most of the ACE inhibitor ends with the pril, but this does not end with the pril, the enalapril, because it is the result of the prodrug. So enalapril is going to be the prodrug of enalapril. So enalapril is actively metabolized into enalapril, which gives the action. And actually in anesthesia practice, you're going to be using enalapril because it's the only one that comes in the IV form. Captopril is the shortest action. It has a shorter action. It also have a sulfur group in it. So we use them. They are the first line in treating essential hypertension. And we also use them in heart failure because they are great. Even in left ventricular dysfunction after the MI, we can also use them. So first line hypertension, left ventricular dysfunction after an MI, even in CAD disease with hypertension. What are the adverse effect versus complication? So going back to this renin-angiotensin-aldosterone system, because we block the ACE, we're going to have an increase in our bradykinin. And like I said before, bradykinin is heavily implicated into inflammation. This increase in bradykinin is going to be responsible of the dry, hacking cough that we see with the ACE inhibitor. And it's also going to be responsible of the angioedema. These are very fatal side effect angioedema, because you can actually lose your patient, right? And I want to make sure you understand that this angioedema is not going to be responsible to epinephrine. Like with most of edema, we give epinephrine. But this angioedema will not respond to epinephrine because it comes from the bradykinin. Epinephrine don't act on the bradykinin. So in order to resolve this angioedema, you have to give the patient the fresh frozen plasma. You have to give the patient the bradykinin inhibitor at the receptor, like actibactin. And you also want to give like complement inhibitor. Remember, complement is heavily involved in the inflammation. So you want to give some complement 1 esterase inhibitor to treat this angioedema. Now, other side effect that you can see with ACE inhibitor, you can have like agranulocytosis, you can lose your white blood count, you can also have basically most of the time it's agranulocytosis, and it's going to be with captopril. Now let's talk about the consideration. Actually, ACE inhibitor has a lot of advantage over the other antihypertensive drug because it's voided of all those depressive action. You don't have all the depressive action that you have with other antihypertensive with ACE inhibitor. You also have no impotence. Most of the patients are not compliant with their antihypertensive drug because of that issue of impotence. But with the ACE inhibitor, you don't have that issue, making your patient more compliant. Um, Interaction. So you don't want to give ACE inhibitor with drugs that can potentially increase the blood pressure. So you don't want to give them with NSAID. NSAID, they increase the blood pressure through the prostaglandin. Metabolism. ACE inhibitor are mainly metabolized in the liver, so you want to make sure to adjust the dose if the patient has a liver failure. The route, most of them are going to be oral except for enalapril, which is going to be given IV. Toxicity is going to be mainly manifested by hypotension. So in case of hypotension, giving ACE inhibitor, you don't want to give norepinephrine or epinephrine, and I will show you why. So if you have ACE inhibitor, because they inhibit the sympathetic nervous system release, because when you block ACE, you're blocking all these things, so you're inhibiting the sympathetic nervous system. Now the body, when you inhibit something for such a long time, the receptor are going to be highly sensitive. The receptor are going to be upregulated because it's something that is not there, so the body is on the guard to make sure when it's there it grabs the most it can. So by inhibiting the sympathetic nervous system here, you are upregulating the receptor, regulation of sympathetic nervous system receptor. And if you give this upregulation in the presence of catecholamine like epi, norepinephrine, and dopamine, you're gonna have a huge surge in your blood pressure. And you don't want to do that, right? You're trying to progressively bring the patient back to a stable hemodynamic place. So usually we use non-catecholamine to treat the hypotension that ACE inhibitor can have during the overdose. So you want to use the non-catecholamine drug that can increase blood pressure. And in this range, you have ephedrine and phenylephrine. So ephedrine is an alpha 1, alpha 2, beta 1, beta 2 agonist, and it's gonna help to increase slowly that blood pressure and maintaining the vasculature, not giving us too much vasoconstriction because it has beta 2 agonism. Phenylephrine is a potent alpha 1 constrictor. It's gonna kind of bring that vascular tone that the ACE inhibitor cancel. So you want also to watch out for that. Now, mentioning about interaction that I missed to say, ACE inhibitor are safe to give with diuretic. Most of the diuretic are going to induce like hypokalemia or hyperglycemia. You don't have that issue with ACE inhibitor because in the normal system of renin, angiotensin, aldosterone is going to be responsible of retention of sodium, and the water is going to follow, and excretion of potassium. Now, if you block this way, you're going to have a tendency to have an increase in the potassium blood level. Now, giving diuretic, you are safe because why? Here you have an increase in potassium. Diuretic are going to flush the potassium, so you're going to be in the even state. So they are safe to give with diuretic. And also, if you have a patient, if you're an anesthetic provider, you have a patient going for surgery and has been taking ACE inhibitor for long, it's okay to abruptly disrupt the treatment it's not like other drug like clonidine that you give and you want to taper the dose. You don't have to taper the dose with ACE inhibitor, which is a great advantage, because most of the time when these patients are on ACE inhibitor, you want to make sure they stop taking the medicine before the surgery, because it has been proven that ACE inhibitor increase the risk of hemodynamic instability during surgery. So you want to make sure that you ask your patient to stop it, and the patient shouldn't be scared because you don't have to taper the dose like other antihypertensive drug, which is also an advantage of ACE inhibitor. And also, when a patient is getting like a cardiothoracic surgery, I don't know, it could be a heart transplant, any other stuff. ACE inhibitor has been proven to cause cardiac vasoplasia. So most of the time, we want this patient and us in ACE inhibitor to stop the treatment before surgery. Unlike beta blocker, if your patient is on beta blocker, you want the patient to keep taking the drug. But with ACE inhibitor, they can stop and next they have their surgery. Um, so this is what I had for ACE inhibitor. I hope it helped. And please, if you like this, subscribe and share around you. If you have a comment, if you have a suggestion, please drop down below and I will see you on my next video. Thank you.